judges, and everyone present over here. Today I am going to present an acute infective suppurative dacryoadenitis presenting as an abscess and ptosis in a child. Coming to the introduction, lacrimal gland abscess is a rare entity, especially in a child, following acute or chronic dacryoadenitis, and of infective origin is very rare. Early and prompt management is needed to prevent visual and life-threatening sequelae such as orbital cellulitis, cavernous sinus thrombosis, and intracranial abscesses. Now coming over to the case report, a 7-year-old female child presented with redness, large painful swelling on the right upper eyelid, which was insidious in onset with low-grade fever. There were no blurring of vision, nasal discharge, prior history of trauma, or insect bite. On examination, visual acuity was 6/6 in both eyes. Pupils were round, reactive, and regular to light. The anterior segment and fundus examinations were within normal limit, and on palpation, there was a tender nodular swelling. However, there was no proptosis, deviation of eyeball, or restrictions of ocular movements. The right upper eyelid was inflamed and warm to touch, tender, and there was also mechanical ptosis. The conjunctiva was hyperemic and chymosed on the temporal side with scanty mucopurulent discharge. On raising the upper eyelid, the swollen lacrimal gland was seen to be bulged out from its undersurface and had a pus point. However, there were no any adjacent skin infections, nor there were any signs of direct trauma. On systemic examinations, there were multiple palpable submandibular lymph nodes on both sides. So we have ordered a CT scan of brain and orbit, which revealed well-defined heterogeneous hypoattenuating thick enhancing wall collection in the right orbit with internal septus. And there was also a central necrotic core arising from the lacrimal gland with obliteration of the orbital septum. Other investigations like TLC were high. CVC showed leukocytosis with predominantly neutrophils. FNAC was done and sent for examination. She was diagnosed with left orbital cellulitis with lacrimal gland abscess secondary to acute dacryoadenitis. So moving on to the management, we have started, after pediatric consultation, we have started her on intravenous amoxicillin and clavulanate 850 mg 8 hourly and topical moxifloxacin 2 hourly and ointment fusidic acid 8 hourly on the right eyelid. But the patient was not improving. So, and we can see here on this picture, there was purulent discharge from the superior fornix, and on digital compression, there was also a pus coming out of the superior temporal area of the right upper eyelid. And here we can see the lacrimal gland abscess with, and the materials were sent for examination and culture. And after that, the temporal fistula lasted for a few days at the drainage site, and the culture of the pus shows staphylococcus, which was sensitive to above antibiotic that we have prescribed her. And she completed 1-week course of intravenous amoxicillin and clavulanate. And on follow-up, there was improvement in the swelling of the right upper eyelid with minimal limitations of the elevation of the left eye. She was discharged with oral amoxicillin and clavulanate twice daily for 2 weeks and on topical moxifloxacin. And after 1 week of discharge, the right upper eyelid looked normal, and there was slight congestion of the conjunctiva and superiotemporal area and crusting over the upper eyelid area. Thank you.
Doctor, you did a scan and then you went and did an FNAC. Do you think it's a little uncalled for to do an FNAC here, considering it was definitely an inflammation or infection, plus there was a whole cavity filled with pus?
Yes, sir.
So, I mean, putting in a needle at that point is definitely not called for, first, number one. Number two, the treatment that was started, considering that the child was so ill, just starting on amoxicillin and clavulanate was definitely not enough. We should have covered it for anaerobic and probably stronger gram negative cover,
So
probably cephalosporins. Number three, I mean, the child's being sent home without complete regression of symptoms, because
So
these
sir, after drainage of the abscess, the symptoms were reduced, and so we have
Okay.
discharged on oral amoxicillin and clavulanate.
Yeah.
So,
Okay, anyway, thanks.
thank you, sir.
Dr. Vivek Singh is here.